All right, now we're going to hear from Dr. Richard Schell. He is the Chief Section of Pulmonary Medicine at Nationwide Children's Hospital and a professor of pediatrics at The Ohio State University School of Medicine. His clinical interests are in the pulmonary complications of neuromuscular disease as well as cystic fibrosis. He is an active co-investigator of the Therapeutic Development Center of the CF Foundation. He is involved in many clinical trials in pulmonary medicine as well as the Center for Gene Therapy at the NCH Research Institute. He has also been active on committees for Cure SMA and Parent Project Muscular Dystrophy. He has been the recipient of the Excellence in Teaching Award from the Department of Pediatrics, as well as the Family Centered Care Award at Nationwide Children's Hospital. He has also been awarded a Golden Stethoscope Award from the Alumni Council of NCH. That's awesome, Dr. Schell. Thank you for being with us today. I know that you've got a great presentation, so I will go ahead and stop sharing, and you can go ahead and start your slides.
All right, well, I'm thrilled to be here, and thank you for inviting me to talk about one of my favorite topics. But I really start by saying that it's really an art to taking care of patients more than anything, and there's certainly an art and skill in taking care of patients with neuromuscular disease. But I really try to organize this lecture on the way my brain works when I see a patient in our MDA clinic. And this is how I started, but it's really key to think about the fact that families really come first, and that patient and family is the leader, or I guess the coach of this team. This is how our MDA clinic is set up at Nationwide Children's in Columbus, but there's multiple different specialties that will see a patient. Many patients know to bring some snacks, and rather than coming to multiple different appointments, we try to schedule them all on the same day. But I always like to remind parents that there's a lot of people coming in and out of these rooms, but don't ever forget, like, if there is something that is on your mind, if there's something that has been bothersome or a clinical issue, please bring it up so that specific specialist can spend a little bit more time and make sure that we have those questions answered. But from a breathing standpoint, well, they laughingly call me a neuropulmonologist in my department, but there's a lot of muscles that we have in our body, obviously, and with muscular dystrophy, I feel like there's a huge focus on the muscles of the legs, the muscles of the arms, mobility. Our physical therapists really work hard to do stretching and things like that, but there's hundreds of muscles that affect breathing and help us breathe. And those muscles also get weak with muscular dystrophy, and we have to really think about those as we move forward, and as we think about what are the things that I can do to help those muscles. Are there things that I can do to help prevent complications from happening? Or is there support that I can give further on in the disease process so that we can have a better quality of life? And breathing, I think, really fits into that. I like to frame it by talking about 4 kind of respiratory stages, and these go along with the other descriptive changes, and it really helps us as physicians and therapists and other healthcare professionals understand where in the disease process the patient is, and help the family and the patient make those decisions on things that we have to think about at various stages. But initially, when we look at pulmonary function, these kids have normal pulmonary function. Just like any other child. These are not the easiest tests to get, but from birth to age 10 or so, we tend to see an increase in the numbers as they grow, as their lungs are getting bigger. But in the early teens is where we start maybe seeing a little bit of change in the strength of those muscles, and we may start seeing a weak cough at that point, in that kind of second stage. And I think in the literature, they would put this into like the mid to late ambulatory stages. That third stage, which might be mid-teens, this is probably around the stage that we're losing more ambulation, or I should say using the wheelchair a little bit more. But we may see normal breathing during the daytime, but we have to think about those sleep studies, like what's happening when they close their eyes, when they sleep, we all get a little bit weaker, regardless of what is going on with us when we sleep. And patients who are already starting at a weak musculature standpoint will get even weaker at sometimes when they sleep. And finally, you know, we're past the mid-teens, we're into the mid to late teens and early adulthood, or, you know, mid-adulthood. And this is where we may see more and more problems with sleep at night, but also a weaker cough. This is where many of the complications can come in, and we may actually progress to seeing more trouble during the daytime as well. So what do we do in clinic? We do pulmonary function tests. I think that from my standpoint, this is the best test that I have as a pulmonologist in the clinic. And it helps us really track the changes. And I always like to tell and say to parents and patients, like, these are just a number. I am much more interested in, you know, the clinical changes. You know, if a young man tells me that he's having breathing and his pulmonary function tests are completely normal, I still am going to go on that fact that he's telling me that he's having trouble breathing, and we need to figure out why. But when you're in clinic, I've listed some of these terms like that the doctors may throw out, but the forced vital capacity is the main term that we use in research. It's really the force of air that they're blowing out when the respiratory therapist is really having them blow hard. But we also look at measures of muscle strength with the pulmonary function tests, and this is the mean inspiratory pressure when they like suck in really hard, the mean expiratory pressure when they blow out into a device really hard. And then there's the cough flow, which is also used in research, and it helps us kind of put a risk level on patients who may need to go to the operating room and have general anesthesia. It also gives us a little bit more information about where we need to introduce newer therapies. The last thing that we check in our clinic, and many other places will check, is a carbon dioxide level. It looks like a nasal cannula that someone may wear oxygen with, but we just have them breathe in and out, and we can measure what that carbon dioxide level is. Many of my elder colleagues would tell me that if that carbon dioxide level is high when you're awake and in clinic, then we probably missed the boat somewhere, and we need to figure out what's kind of going on at night as well. I would also say that this is very effort dependent. I know some of these young boys and young men may have some behavioral components to their disease process, and it really takes a good respiratory therapist to work with them and try to get the best number that we possibly can. And sometimes it takes many practice tries to get to that, to get them used to this, to get them to understand it doesn't hurt at all. But behavior can sometimes get in the way. So we use the pulmonary function test to track the strength. And once we see that cough flow and the forced vital capacity get to a certain point, we will start talking about what can we do to prevent complications from happening. And the cough assist, it's also been called an inexsufflator. The cough assist is the more gray one with the digital screen at the top, and the other one is VitalCough. They're two different companies. It's a device that does the same thing. I always talk about it like a vacuum cleaner. It helps you take a cough. If you think about having to cough, you have to take a really deep breath in, and then your brain automatically closes a bunch of muscles, and then you build up pressure and you cough, and you're able to get that stuff out. When your muscles get weak and you can't get your diaphragm to the right spot, this cough assist will help you take a really big deep breath, and then it will suck it back out. People have to get used to this. Some people don't like it. It makes some kids and adults anxious. Sometimes I'll just use the part of the breathing in, and I'll have the parents take the mask off and let them cough on their own. There's also ways to do this manually. Some people like to do abdominal thrusts. Some people like to use an ambu bag where you help them take a big deep breath with a bag and a mask, and then just have them cough on their own. But I would absolutely say that if we're having trouble clinically clearing secretions, or pulmonary function tests are at a point where we feel like the cough is having some difficulty, I would absolutely recommend getting this. In fact, I would probably demand from your clinic that this is something that is needed. And this is probably our best equipment from a prevention standpoint. It's your ticket out of the emergency room, out of the hospital, or preventing the hospitalizations. But this is your way to clear secretions so that we don't have the pneumonia and respiratory complications that can come with the weak muscles from a breathing standpoint. This slide, however, is repeating that because it's such an important point. But this slide is really for any of the young men who might be on here. I look at the cough assist, I look at BiPAP or ventilation, kind of like a wheelchair for your lung muscles. If I were to take away a wheelchair, there would be no mobility. And again, it's the important thing about thinking about the fact that our lung muscles are also getting weak with muscular dystrophy, and we need to help them. So again, chest therapy is the most important preventative therapy you can do when your muscles are weak. And I like to tell my patients to do it once or twice a day, just on a regular basis. Though I haven't been able to prove this yet from a research standpoint, I really do feel that people who stretch these muscles and clear those secretions have more stable pulmonary function and stay healthier for longer periods of time and prevent the complications. But like I said, this machine is just like a wheelchair for your lung muscles, and if it had wheels, it would move on. And that is actually my first attempt at animation a long time ago with PowerPoint. I wanted to mention the therapy vest. So this is a device that is approved for cystic fibrosis. And in the world of neuromuscular disease and pulmonary kind of complications, we've stolen a lot of stuff from what we've learned and how to clear secretions in CF and things like that. This is not, however, a device that I think every young man with Duchenne needs. I believe that there are a group of patients who have recurrent pneumonia for one reason or the other. Maybe they have bad scoliosis, maybe they've been in and out of the hospital a few times. Maybe there's other extenuating circumstances. And I don't always agree with all of my partners. Some of my partners use this device a lot more, but it's very expensive. If I have a patient who really wants it and is going to use it every day, then all power to us, we'll get it. But it probably works better in a hospital situation where patients are really needing to clear those secretions. But the thing that you have to remember is, if you use the vest and you move the secretions around in your lungs, it really is not going to make any difference unless you do it with the cough assist and help them clear those secretions. So I never do a vest without a cough assist, but the cough assist you can do on your own. So I briefly mentioned scoliosis in another slide, but scoliosis is something that from a lung standpoint, I know it's a spine, but it affects the way kids and adults will breathe. This is a little bit more technical. There is definitely good evidence that if we are able to correct the problem or correct that spinal curvature with surgery, that patients tend to do better overall. And if you are at that point where you need surgery and we combine that surgery with respiratory support using BiPAP or non-invasive support, we know that these young men will do better quality of life and live longer than if we don't do that. But scoliosis, because the muscles that are keeping our spine straight are also weak, they tend to lose that support to the spine, and young men can have pretty significant scoliosis without even knowing it. So it's very, very important to make sure that there's somebody in the clinic that's assessing this, as kids lose ambulation and may be in the wheelchair more. This is just a slide from a very well done study. It was done a long time ago, but this is basically just showing on the graph. I think you can see this, but the lower curve is our patients, the percent survival and age. So the basis of this kind of study was just to show that this middle curve is patients who had BiPAP use and they lived longer, and this third curve was really those patients who had scoliosis and had surgery and had BiPAP. They also extended their life and had a better quality of life. So I'm just trying to show this to hit home Like, not all kids will have spinal surgery, but it is something that if they have scoliosis, I highly recommend making sure that we have people evaluating that. Our physical therapists can help, our occupational therapists, our orthopedic surgeons, and trying to find the right time to do a surgery like that takes a lot of thinking as a team, especially from a respiratory and surgical standpoint. So another thing that we do in the clinic, well, actually we don't do it in the clinic, but the things that we talk about in the clinic are sleep studies. You know, once somebody gets to a point where their forced vital capacity is about 50 to 60%, or if they're having any sleep time symptoms at night, or if they have lost ambulation, it's recommended that you have a baseline sleep study. Sleep studies aren't available really at every center, but I know that they are relatively easy to get at times. That technology is getting a little bit better, that some of them may be able to be done at home. But the important thing to remember with a patient with muscular dystrophy is that it needs to be a sleep study where they're monitoring their carbon dioxide level or the bad gas, the gas that we exhale, because that's what we're looking at night. If the sleep study is not measuring that, then the sleep study really won't help us as a pulmonary group to decide whether or not support is needed. Other things, and I've talked to you about the fact that clinical changes are important, but if you're seeing behavioral changes in your kids, if they're feeling more tired during the night, during the daytime, if they're waking up more, I always ask the question, like, have you had to roll more at night? Have you noticed, have they gone from maybe a baseline of waking up 1 or 2 times a night to a baseline of 5 or 6 times a night? These changes could really tell you that there's something going on at night that we need to investigate, and the sleep study is probably the way to do that. If snoring is big, younger kids who are on a lot of steroids tend to gain a lot of weight at times, and their tonsils and adenoids can get big, so they can have some obstruction. But what we're really looking for with sleep studies is something called hypoventilation, or that shallow breathing at night that doesn't let you get the oxygen and the carbon dioxide out as well. Headaches in the morning specifically can be a sign of an elevated carbon dioxide level in the morning. And then we also want to watch the pulmonary function as well to help us decide when the best time to get a sleep study is. Once we have the sleep study, then we can make a decision on what's needed. But this is just a schematic looking at what happens with neuromuscular patients. So if you start with some neuromuscular weakness, we're wanting to look to see what's happening at night. Like, you may hear the terms hypoxia or low saturations or oxygen dropping. So that's the good gas, that's the oxygen, and that drops sometimes at night with obstruction, but it can drop at night with hypoventilation as well. But more with hypoventilation when they're sleeping, the bad gas, the carbon dioxide level will go up, and that can cause problems long term. It may, like I said, cause more waking up or less sleep or more poor sleep. It can lead to daytime symptoms, which then again increase that bad gas, and that leads to the need for the support that we can provide to prevent this from happening and to make sleep much better. And as everybody usually knows, if you don't get a good night's sleep, you usually don't have a good day. But sleep can really affect your health and your overall well-being. So when we talk about breathing support with muscular dystrophy, this is after a sleep study, this is after we have some data, but some patients will eventually need non-invasive ventilation or BiPAP. The important thing to remember is if we get to this point, BiPAP or biphasic, or it's a device that gives you both inspiratory and expiratory type support, that's the one we need. Some people get put on CPAP, and I'm not going to say that that's wrong, but CPAP doesn't always give all the support, and patients with neuromuscular disease usually need that bi-level support. It helps you get a good breath in, it keeps your lungs open at night, and overall it just takes that work of breathing away. Once we get to a point where non-invasive ventilation is not helping all the time, we can talk about invasive ventilation, and there are patients out there that choose to have a tracheostomy tube, which is a piece of plastic that goes into your airway that allows you to attach ventilatory support to that. but this is really a patient choice, and I was not going to delve into it a lot with this presentation, but it is a conversation to have with your physician if you're already on support and you're using it more than 16 hours a day and it's really affecting your quality of life. More invasive ventilation may be something that you could choose, or you could at least talk to people about to see what kind of options would be available for you. I wanted to specifically, well, just briefly talk about the role of pulse oximetry. This is the SAT monitor, or, you know, some people call them the oxygen monitors. And, you know, I put here that all patients with neuromuscular disease who have the need for a cough assist or have the need for BiPAP at home should have a pulse oximeter at home. And I say that with a grain of salt because pulse oximeters are not always the easiest things to get, especially from home care companies, though my understanding is that you can get a pretty good one online for about $150 that just attaches to your finger. But I think pulse oximetry at home can be helpful. If you feel like oxygen saturations are low and somebody needs to clear their cough or secretions, it can help kind of guide your therapy a little bit. It also tells you what your oxygen saturation is. And I'm going to talk about this a little bit more as we go forward, but there's a big thing about don't use oxygen in muscular dystrophy. And that's true, and it's also false. We have to use oxygen when we need it, but there's a lot of things that we should do first before just throwing oxygen on. And I think that, you know, if you're able to have a pulse oximeter at home for a young man or an adult who is on support, I think that that could be helpful, but it's not as good as you using your eyes and your clinical skills above the machine. So with that being said, I'd like to talk a little bit about emergency care, because there are lots of emergencies that can happen with muscular dystrophy, but the pulmonary emergency care and the care of a patient around the need for any kind of surgery is, I think, an important part to talk about with pulmonary issues overall. So emergencies can happen, and I think we always want to be prepared. Prevention of complications is the best approach. So as soon as you get a cold, if you have a cough assist and you use it once or twice a day, you should be using it 3 or 4 times a day to try to prevent pneumonia. You should always have a place where all your doctors and those numbers are available. And when you get to an emergency room or a place that they may not know you, just never feel ashamed to say, hey, I have Duchenne, my son has Duchenne. Like, make sure the treating team is aware of the diagnosis. And, you know, that I'm going to be talking about respiratory care, but, you know, if your child or your young adult is on steroids, they need to know that, especially if it's a stressful situation, or if there's any cardiac complications that they need to know about. So it's nice to have that stuff written down so that the doctors and nurses, if they're not aware of muscular dystrophy problems, that you can work with them to help your child, but also to educate them as well. So breathing emergencies, again, oxygen should not be used without first making sure that your CO2 levels are normal. If your carbon dioxide levels, the bad gas, if they're too high and you just throw oxygen on, sometimes that will slow your breathing even more. It's just the way the brain works. But I would say that as compared to just putting oxygen on, the emergency you should be prepared to do the cough assist, to use non-invasive ventilation. If you're doing all the therapies to help clear those secretions and the oxygen is still low, then absolutely use the oxygen. It's not, when I teach my residents, I'm like, just don't put oxygen on and sit somebody in the corner and be comfortable that those saturations are okay. But if you have them on oxygen, make sure you're doing the cough assist, make sure you're giving them the support, and make sure you're, you know, checking, especially if they have a pneumonia or they're in some respiratory failure. And the last thing I really want to talk about, so that I have some time for questions, is really that if anesthesia comes up, at Children's where I work, we created a neuromuscular protocol so that patients who have muscular diseases, we can alert the anesthesiologist and we can make sure that we're prepared for any issue that may arise. If patients are already on BiPAP or non-invasive ventilation, then we have a plan in place for the post-operative care. But there's these three kind of considerations. You want to make sure you're prepared pre-operatively, that the whole team is ready to go. During, there's some issues that the anesthesiologist should be taking care of, and after, this is when the respiratory care comes into a more important role to clearing those secretions when you're still a little bit sleepy. So before you have any surgery, you should really make sure that you have this evaluation. Make sure that they've done pulmonary function testing if your child or you are able to do it. If you can check oxygen saturations, and if they check carbon dioxide level, that can usually help the anesthesiologist know what the normal level is at baseline. It's important to make sure you're in good nutrition, especially if you have difficulty swallowing or have difficulty getting enough calories in. And always ask questions about your risk of going for general anesthesia. So again, a proactive approach is best. Pulmonary and cardiology assessments are essential before surgery. And before you go into the OR, make sure that you're talking and speaking to the anesthesiologist. So during surgery, and I don't want to go into too much of this, but you should try to request intravenous, so IV anesthesia if possible, because there are some drugs that may affect patients with neuromuscular disease a little bit worse than others. Succinylcholine is an absolute contraindication. I would be amazed if there's an anesthesiologist at the places that you go to that wouldn't know that they can't use this drug, but it never hurts to ask the anesthesiologist if they're aware of complications with muscular dystrophy. And we usually recommend that they use IV anesthesia and not the inhaled anesthetics, because that can sometimes cause an increased risk as well. And there's many other medications that are out there that are available. But like, again, this is really just to have it in the back of your mind so that when you're meeting with those people prior to going to the operating room, or your child is about to go back there, that you feel comfortable that they know what Duchenne is and is how to treat it. And then after surgery, if you already use BiPAP or your child already uses BiPAP, I strongly encourage you to be at a place where they're able to take the breathing tube out and put them right on BiPAP right after surgery until they're wide awake and they're able to breathe on their own again. At our institution, we tend to take that tube out in our intensive care unit and let our ICU doctors help move from the OR to the BiPAP. And once they're fully awake, we take that BiPAP away and we help them go on from there. But again, with your team, discuss where that recovery will take place. I think discuss if there's, if you're using the cough assist, do you have oxygen available? Are they going to be monitoring CO2 levels? And really to have a plan in place to optimize pain control, not only because I don't want anybody to be in pain, but pain meds can make you sleepy and that can affect how you breathe as well. So really, the bottom line right now for me is that proactive screening of any respiratory symptoms should be done at each visit when you see your MDA team. You should at least have yearly pulmonary function tests when available. If they're able to perform the test, or if the behavior issues are severe and that inhibits the testing, then we can work as a team to try to figure out other ways to do testing. You want to stay on top of your nutritional issues and swallowing, especially if there's issues with losing weight. You want to have the technology at home to help keep you out of the hospital, like the cough assist. Screening for sleep disorder breathing at each visit, and sleep studies where there is a notable loss of ambulation, or early if there are symptoms prior to that. And you want to make sure that you have an awareness of new symptoms, and you want to ask about it in clinic, and again, have that emergency plan. So I think that I went a little bit faster than I expected, but I want to make sure that there is some time for questions if there are any, and I will stop sharing my screen, I guess, or should I leave it up, Nicole?
You're fine. You can leave it. That's good. So I thought it was interesting. You had said screening for sleep disturbances at your visit. How do
Mhm.
you do that?
So there's a lot of questionnaires. There's a lot of sleep questionnaires that people will use. It's really, I just screen one. We do pulmonary function tests, so I know
Okay.
where their pulmonary function level is.
Okay.
If your pulmonary function tests are 100% and you have no symptoms, I'm probably not going to do a lot of screening.
Okay.
But we'll always ask, do you snore? Do you wake up a lot at night? Are you tired during the
Got it.
daytime?
Okay.
Do you have headaches? We're big
Okay.
on asking these headaches. So it's really just the history that you're getting that will kind of set alarms off in some of our pulmonary heads saying, hey, maybe I should ask a couple other questions about this and see if there is something else going on at night.
Okay. And is there a recommended time frame to get a sleep study? Once you get a sleep study, I guess, do you repeat that, or do you just come back for a repeat visit if you're still having issues? How do
So
you
that
handle
is a great question. I think that I will, if I get a patient who has symptoms or a patient whose pulmonary function gets to a point where I think, we should have a baseline study.
that? Mhm.
If you read the guidelines that are out there, it's written that you should have a sleep study every year. I don't,
Okay.
I don't really agree with that. That is published stuff, I think that I'm on a lot of committees that were rewriting a lot of these protocols, and I think it's really, to me, it's more based on symptoms. If you get a baseline sleep study, which is completely normal, and you have no symptoms, and it goes 2 or 3 years before you have some symptoms, then once those symptoms start, we should probably recheck it. But if
Okay.
pulmonary function, if there are other data points that are dropping more than we would expect, then your pulmonologist will probably suggest that we should probably look, because some of the symptoms are pretty silent, and
Mhm.
we've certainly picked up lots of young men who have some sleep disordered breathing, and we've made a huge difference in their quality of life just by supporting their sleep a little bit more and picking them up a little bit earlier than we would have with like the clinical symptoms.
Okay. All right. That's great. I I do not see any other questions. So I just want to thank you very much for your time today.